Assalamu alaikum, everybody. This is Iqbal Ahmed from Dallas, Texas, on behalf of Apna Merit. A really warm welcome to all the panelists and all the attendees. We'll have a great discussion today. Our guest speaker is Dr. Asima Cheema, who's Medical Director of Genesis. I will now request Dr. Cheema to please introduce herself and proceed with her titled lecture, which is CDC Guidelines Update. Thank you, Dr. Cheema.
Thank you, Dr. Iqbal. Bismillahirrahmanirrahim. Assalamu alaikum, everyone. I'm Asima Cheema, practicing internal medicine in Maryland. As we all know that we are going through a tough time all over the world. That's why we are here to share knowledge with each other, learn from each other. And of course, with Allah subhanahu wa ta'ala, definitely will come out of it. And this hard time, we have to have strong belief on Allah subhanahu wa ta'ala, it will get easy. And I would like to share Quranic verse with you first. Quran says, Inna ma'al usri yusra, indeed with hardship comes ease. So inshallah ta'ala, we'll get through it, and this will go down some point. And today I'm going to talk about the CDC guidelines and clinical trials going through over here in States. And before going there, I would like to share Johns Hopkins data as of today, how many cases has been confirmed. So total cases confirmed per Johns Hopkins data is more than 2.5 million cases. And out of those, more than 176,000 deaths has been confirmed. And this data is for about 5 countries. And country-wise, most of the cases are in the United States. It's more than 823,000 cases has been confirmed, then Spain, then France, Germany, United Kingdom, and so on. In United States, more than 820,000 cases has been confirmed, and out of those, most are in the New York state and in New Jersey state. So these are 2 states are epicenter at this time, and of course, it's spreading all over the state. The cases as of today in Pakistan is 9,565,000 cases has been confirmed, and of course, the numbers are increasing every day, and that's why we are here to share knowledge and learning with each other to help each other. And the fatality rate worldwide, based on this Johns Hopkins data that I calculated, was 6.9%, and in the United States is 5.4%, and in Pakistan is 2.1%. So based on these really alarming numbers, so we have to keep talking about flatten the curve. Of course, it's very important, public awareness and being healthcare providers, very important. We all have to do public awareness to help this curve to be flattened. So as we know, there are a lot of, we don't have any treatment at this time, but of course, a lot of clinical trials undergoing at this point. I was calculating about 144 clinical study trials I have seen online available. They're still some are under recruiting, some are active. And in China, they had a couple of studies that they have stopped regarding one of the drug, remdesivir. I will talk about it. So right now, there are no drugs or other therapeutic approved by the FDA to prevent or treat the COVID-19 at this time. And it's really an alarming situation. And of course, clinical management includes, again, infection prevention and control measures and supportive care, including supplemental oxygen and mechanical ventilation support when indicated for severe cases. And again, we talked last time, there was mild to moderate cases, 81%. That's a good thing. This means that we don't need treatment in those 81% of the cases. Again, supportive care is needed. And out of 14% of the severe cases that need to be admitted, and out of those 5% of the critical cases. So we are talking about the remdesivir. This is one of the medicine under clinical trial at this time. It's an antiviral activity. It's again investigation drug at this time that inhibits the viral replication, and it has not been approved by any regular authority at this time because safety and efficacy data is not available. But the expanded access treatment protocol is going on, and Gilead is one of the pharmaceutical companies currently in the process of transitioning the provision of this emergency access to remdesivir from individual compassionate use. Right now it's clinical trials. So they are trying, getting approval from the authorities that this medicine should be available on the basis of compassionate use. And they're still under process so they can deliver this drug for the patients all over the world and accelerate the gathering of data outside of clinical trials. Since we don't know which medicine we have to use, so I just put the inclusion criteria and exclusion criteria for this study that is undergoing, or at this point, which are the including criteria we need to be considered. Of course, we don't have any data available, but I just put the including criteria. It will give us some idea that which trial, which medicine we can think of starting for our patients. For remdesivir trial, including criteria, of course, we need informed consent, and for the patients more than 18 years of age, or if patient is less than 18 years of age, or more than it should be more than 12 years of age. It's based on the weight. It should be more than 40 kg if we are planning to give patients or who are less than 18 years of age. And this is what IRB is approving. And of course, we have to give this to the patients who are hospitalized and they are confirmed by the PCR. And of course, patients are requiring invasive mechanical ventilation. And another including criteria is ALT should be less than 5% upper limit of normal of the by local labs. In the exclusion criteria, which they mentioned in their trial, is the evidence of multi-organ failure. It's not limited to only just thrombocytopenia. It's include hepatic failure, renal failure, and of course, significant cardiomyopathy. And of course, another exclusion criteria is when patient is on more than one pressor for septic shock. That is another exclusion criteria. And of course, renal failure when GFR is less than 30 ml, or if patient is on hemodialysis. And of course, if there is any hypersensitivity to the study drug, those are exclusion criteria for this. And another medicine we all know, hydroxychloroquine and chloroquine, is still under trial. There is no data available at this time. And this, of course, is oral prescription drug available, and clinical trials for pre-exposure or post-exposure prophylaxis for COVID-19 infection and treatment of patients with mild, moderate, and severe COVID-19 patient is still under trial. But FDA has issued emergency use authorization to use in patients who are severely ill, hospitalized patients. And again, healthcare providers are responsible for submitting patients' outcomes for any serious side effects and medication errors, if God forbid it happens, for this emergency use authorization to one of the medical product safety reporting program called the MedWatch. So FDA, this is how FDA is controlling this hydroxychloroquine use, but still is under trial. Another, we heard about the plasma. So FDA has issued guidance for administering for use of clinical trials. And there are the two different pathways for use of the investigational COVID-19 plasma. One was the clinical trials. We all know that is under trial and should be submitted request to FDA for investigation use. Other one is expanded access. And it is an alternative for the use of COVID-19 plasma for patients with serious or immediately life-threatening conditions, disease who are not eligible for the randomized clinical trials. So these are the two pathways that FDA approved at this point that we can use it in these two circumstances. And again, we don't have any scientific data available. And the patient eligibility for the plasma, I just want to go over pretty quick over this. Patients who were, of course, confirmed COVID-19 positive, and if they are severely or immediately life-threatening conditions like dyspnea, respiratory rate more than 30, blood oxygen saturation less than 93%, and PaO2 to FiO2 ratio less than 300, and lung infiltration more than 50% within 24 to 48 hours, and also the life-threatening conditions like respiratory failure, and septic shock, and multi-organ dysfunction failure, we can try this patient eligible for this. And of course, we need a patient informed consent by the patient or the healthcare proxy before giving plasma. And of course, how we have to collect it. So the donor eligibility based on two different things. First of all, the donor has to be positive for the COVID-19 by any test like PCR test or by the positive serologic test for COVID-19 after recovery. And other criteria is patients need to be symptom-free for at least 28 days prior to donate the plasma, or there is complete resolution of symptoms at least 14 days prior to donation and negative test results. So these are the two things we can consider, either 28 days or 14 days plus negative COVID testing. So those patients can donate their plasma for this.
May I just suggest if you can put your presentation on the slideshow mode?
Okay, let me.
A little more clear for the attendees. Thank you very much.
There we go. Okay, thank you. Thank you, Dr. Paul. Appreciate it. Thank you for letting me know. It's clear now?
Much better. Thank you.
All right, thank you. So another trial we know about TOSI. So this one trial, there are multiple trials going on. As I mentioned, 144 studies are going on at this point. So TOSI to prevent clinical decompensation in hospitalized non-critically ill patients with COVID-19 pneumonitis. So this study designed based on the summary was that hospitalized patients has mortality rate as high as of 25%. So this high mortality rate may be driven by the hyperinflammation resembling cytokine release syndrome. So this is offering the hope that these therapies targeting the IL-6 axis therapies commonly used to treat the CRS, it can be used to reduce the COVID-19 mortality rate. And this is the retrospective analysis at this time of severe to critical COVID-19 patients and who are receiving TOSI at this point. And they demonstrate the majority of the patients had rapid resolution, that is within 24 to 72 hours following the administration of both clinical and biochemical signs that are clinically we monitor the fever, and the biochemical sign we can see the CRP respectively. So we can see the hyperinflammation with only a single dose of TOSI. So still it's under trial and we don't have any data available. And the primary outcomes they mentioned that what they are looking for, the outcomes of this trial is the clinical response assessed for the 24 hours period after TOSI administration, and the resolution of fever with Tmax measured by the commonly accepted clinical methods. And the primary endpoint is the absence of the Tmax, like 38 degrees Celsius or completely absence of the fever. And the biochemical response they will monitor is every 24 hours during patient hospitalization for up to 4 weeks after TOSI administration, that is CRP normalization rate. So these are the two criteria they will monitor, and of course they are doing right now, but again, we don't have any data available at this time, but these are the things I'm just bringing up so we can monitor if we are planning to give TOSI to our patients in the hospitalized critically ill patients. And again, time to CRP normalization is calculated as the number of hours between TOSI administration and first normal CRP value. And this study's under inclusion criteria is based again for adults more than 18 years of age, and of course approval by the patient's primary service, and fever of 38 Celsius, and of course patient positive for the COVID-19 infection, and again radiographic evidence of infiltrates on chest X-ray or CT scan, and a patient's ability to provide the consent, or any legally authorized person can authorize this. So exclusion criteria for this study is the patient who are on the mechanical ventilation are not enrolled in this study. That's why you have to be aware of it. But patients receiving the CPAP, BiPAP are eligible for this study. And another exclusion criteria is patients who are on vasopressors are not excluded. And again, patients who have already received TOSI in the past, they are not included in this study, and who have a hypersensitivity to TOSI. And again, patients who are actively receiving any other antiviral agent are excluded from this study. And of course, a diagnosis of end-stage liver disease and elevation of AST, ALT more than 5 times the upper limit of normal, and neutropenia less than 500, thrombocytopenia in patients less than 50,000, and patients on active therapy with any other biological immunosuppressive agents. So I'm just giving you this idea for inclusion criteria and exclusion criteria. If anyone plan, okay, we have to give to our patients. So these are, you have to keep in mind, okay, should we start TOSI or should we not start TOSI, because we don't have any scientific data available at this time. So there's another study going on that evaluate the safety and efficacy of TOSI in patients with severe COVID-19. Criteria for this is a hospitalized patient with COVID-19 confirmed by per WHO criteria, and evidence by the chest X-ray or CT scan, and SpO2 is less than 93%, or PaO2 or FiO2 ratio is less than 300 millimeter of mercury. And exclusion criteria for this study was, again, allergic reaction to TOSI. Any active TB patients cannot have it, and any suspected active bacterial, fungal, viral, or any other infection beside COVID-19 patients are excluded for this. And of course, per investigation evaluation, if they think that a patient is at imminent death within 24 hours, they have excluded those patients as well. And of course, if patient had received any other oral anti-rejection or immunomodulatory drugs, they are excluded within last 6 months. So they are excluded, and patients excluding other clinical trials, they are excluded from this study. Of course, pregnant and breastfeeding patients are excluded. Of course, in this study, they mentioned ALT or AST more than 10 times of upper limit normal, detected within 24 hours. So they are, the prior study I mentioned, they mentioned less than 5 of upper limit normal. So in this study, they said more than 10 of upper limit normal of liver enzymes. And of course, count, they mentioned less than 1,000. The other study I mentioned, they mentioned less than 500. And again, platelet count is the same, less than 50,000 at screening at baseline should be excluded from this study. So there's another study I go through was gargling and nasal rinses to reduce the oral and nasopharyngeal viral load in patients with COVID-19 infection. And the primary outcome measure for this study they mentioned was to reduce the viral load in nasopharynx and oropharynx via a swab for viral PCR will be taken at the end of each day for 7 days. So this is how they check every day and for 7 days, and then they will this is the primary outcome measures for this study. And again, inclusion criteria, positive test for COVID-19, age range between 18 to 79 years of age. And of course, patient is willing to do that. And of course, able to perform oral goggles and nasal rinses 4 times a day. And exclusion criteria for this study is again, patient on mechanical ventilation and the patient who are unable to do these goggles 4 times a day, and any history of chronic upper respiratory tract disease, and any iodine allergy patients cannot be enrolled in the study, and of course, history of thyroid disease. So again, this will give you some idea that we can offer these remedies to our patients based on these inclusion exclusion criteria. Excuse me. So another study is hyperbaric oxygen therapy as a treatment for COVID-19 patients. Again, including criteria for these is patients more than 8, again, positive for COVID-19, CT evidence of interstitial opacification, oxygen saturation less than 90% on room air, and PO2 55 to 70. And excluding criteria for this study is increased oxygen requirement, hemodynamically unstable patients, MAP less than 65, bradycardia less than, heart rate less than 50, any history of severe disorder, and pneumothorax, and of course, renal failure, GFR less than 30, patient on hemodialysis, and any patient who has claustrophobia or refractory anxiety disorder, and of course, pregnant ladies cannot have it, and uncontrolled correctable hypoglycemic patients are excluded from this study. I'm going to talk briefly about the ECMO in COVID-19 patients. ECMO, we know, involves both removal and return of blood through the veins, usually near the heart, and is used to support the lung function only. And ECMO is commonly used in patients who have heart failure and lung failure, despite use of medical therapy to allow to recover. And there's a ELSO, Extracorporeal Life Support Organization. I got this data from their website. They mentioned that they are using it in COVID-19 cases on the who are on ECMO. And this ELSO registry showed that they show very good positive outcome. That's 36 out of 90, about 40% patient had a positive outcome. And this data is all over the world. North American patients, there were 335 patients, and the European 122, Asian Pacific was 15, and Latin American 11 patients. So this is all the data they have on their website available, that it has a positive outcome. 36 out of 90 patients discharged alive after using this ECMO. So there are other trials going on as well, nitric oxide therapy, a double-blinded placebo-controlled trial going on. So they are doing, of course, this is a very tough time, very stressful time for everyone, for healthcare providers, for patients, families, everyone. So they are doing on some mental health impact trials as well, some mindfulness during COVID-19. So these are multiple trials. I just want to briefly going over this. So these are all the trials going on. Last time I talked about ventilation management. I'm not going to go over it again, just briefly, as we are going to, Dr. Shai already mentioned that at the end of this weekend, we're going to start vent management sessions, and it will be really helpful for everyone. And again, there's a one, I will just put a slide for Howard University is offering the free course. It's a 1-week course for mechanical ventilation for COVID-19 patients. They open it on April 6th, and it's open till August 31st. Anyone interested can join this one as well. It's about a 1-week duration, and time commitment is about 2 to 5 hours per week. So anyone interested, or anyone of your colleagues is interested in doing that, so you can share this information with them as well. So these are all my citations, and I will stop over here and we'll go by question and answer session. So make it more productive. Thank you, everyone.
Thank you very much, Dr. Asima Cheema. I will now request all the panelists to introduce themselves. So, Walid, if you can unmute our panelists. And I'm going to start with Dr. Shahid Rafiq, who is the co-chair of Apna Merit. Thank you, Shahid.
The shorts that you put in my closet.
So, Dr. Shahid, would you please introduce yourself?
Hello.
Yeah, we can hear.
We can hear you. We're just introducing the panelists. So you're number one.
Okay, sorry. Shahid Rafiq, I'm a neurologist in Frederick, Maryland, and Apna Merit Chair. Thank you.
Dr. Shamsa Humayun, please.
Ji, Assalamualaikum.
Walaikum Assalam.
I am Dr. Shamsa Humayun, Professor and Head of Gynae Department at Fatima Medical University, Sir Gangaram Hospital, and I am Vice President, Society of Obstetricians and Gynecologists of Pakistan.
Welcome, Professor Humayun, Professor Shamsa Humayun. Dr. Bushra Ali.
Assalamu alaikum. I'm Professor Bushra Jamil. I work at Al Khan University, and I'm also the president of Medical Microbiology and Infectious Diseases Society of Pakistan.
Dr. Fivzia Harakar.
Assalamu alaikum. I'm Dr. Fivzia, internist and infectious disease consultant at Indus Hospital, Karachi, Pakistan.
We also have Dr. Mariam Motin from California. Could you please introduce yourself?
Assalamu alaikum ji, I'm a non-invasive cardiologist from Loma Linda, California.
Thank you very much to all the panelists for making themselves available. And now I'll open the session to question and answer from the audience and as well as the panelists. So let's see. We have a raised hand, Dr. Muhammad Salim. If you would like to go ahead, introduce yourself and
me and we can immediately courier some of the PPE to his institution, but he has to email us and I can share the email. The other thing is this, Dr. Bushra, that's fantastic that the course is on, but I think it is so very important. I really appreciate that effort that people don't know about this course. For example, we all know about Merit Apna, but somehow we don't know about that course. We had to go to Dr. Sobia, infectious disease specialist at SIMS. She shared a video how to don and how to, doff and don. So basically, we all looked at the video with our fellows and the doctors and everything. So I think we have to have trainers. We have so many people who are in medical colleges. The colleges are closed. Online classes. I think we have to do like a crash course of training, the medical personnel who are doctors and frontline. So that's my comment. Thank you so much.
Thank you very much, Dr. Nigat. All great ideas. I do have another question for Dr. Bushra related to the BCG discussion. And considering all the limitations of BCG as a long-term protective agent that you mentioned, is it at all possible to have the data from the patients in Pakistan who were diagnosed with, by testing with COVID-19 and also with their BCG status and data on the ones that actually ended up getting complications and let's say had severe complications and didn't survive? Would that be something that's even possible to collect as a baseline measure to look into this?
That will have to be done prospectively. because retrospectively, nobody asks this question. The patients who have died, there's no way of knowing whether they were vaccinated or not. People don't recall that. And childhood vaccinations became a norm, I think, 25 years ago. So elderly patients generally do not have a history of BCG vaccinations. It's the young individuals who have been receiving this vaccine with some consistency. So yes, I think this is important to, actually we should start collecting data on BCG vaccination in whosoever comes in with COVID, and irrespective of the course of infection.
Thank you. That's an interesting, I mean, I know that there are several people from the people who are in their 60s who were vaccinated in Pakistan with BCG, but yes, it wasn't part of a national program. And interestingly, Iran apparently did not have vaccination till 1984. So anyway, something to look into. I'm going to go to Dr. Salim, who's raised his hand for a question. Dr. Salim.
Hello. Assalamu alaikum. I'm again here. I have a comment and also a question. My comment is regarding the training about the proper donning, doffing, and use of the face masks. Yeah, there are certain videos and things on WHO site and Public Health England. And we here in Kotli, we trained all our doctors, our paramedics, and all our junior staff. And they are very beneficial. My question is regarding, could you kindly tell me that how do you reprocess these N95 masks and other PPEs, and do they maintain their efficiency or their safety after reprocessing? Thank you.
So I can start addressing this question because I've been involved with the COVID-19 preparations at our children's hospital. So first of all, we could not have access to N95s. We didn't have any positive patients within the institution, and they wouldn't allow us to wear N95s even in the operating room for aerosol generating procedures, which we get involved in. So it became a very serious problem for us. Our National Anesthesiology Association has put out an advisory that all aerosol generating procedures like intubation and extubation should have full PPE with unknown COVID status. So that's what we are following. So the hospital did not have a reprocessing system in place. It took them about 10 days to get it in place. So when we finish our day's work, the N95 is removed according to the CDC guidelines. It's kind of taken off in the doffing process. It's put into a brown paper bag, left into a storage facility where it's collected, and then they are batch processed and re-sterilized with ultraviolet radiation. So these ultraviolet radiations are present in many hospital operating rooms to sterilize equipment and facilities. That is what is being chosen by our institution that has a 95% success rate without damaging the mask. The mask can go through about 4 or 5 cycles of usage. I'm talking about the N95 mask. And if it's not the mask itself, but it's usually the straps that get torn off. So we haven't got to the 5th cycle yet, but I have certainly used my N95 about 3 cycles, and we label it with the doctor's or nurse's name and date of first usage. So that's one method. The other method is hydrogen peroxide vapor. That has been shown to be quite effective in some institutions. If you are interested, I can send you the entire list and the data on efficacy of reprocessing N95s. The face shields can be cleaned, spot cleaned right after you take them off. We don't reprocess them. We clean them with Oxywear or a Sani-Wipe, and they can be reused unless they are grossly contaminated. The gowns, of course, we do not recycle, usually the disposable gowns. If you're using fabric gowns, they'll need to be processed through your sterilization process. So that's the summary of what we do. Hopefully it's useful. I will welcome other panelists who have other experiences or would like to add to this, especially the people who are in infectious disease.
Definitely, I will second Dr. Iqbal. We're doing the same way. This is I would say, definitely, I agree.
Thank you.
Thank you so much.
What about surgical mask?
So yes, actually, very important question. The surgical mask we use, we put that over the N95 in order to keep it from getting splashes. You know, we have a face shield, but the surgical mask protects us from gross contamination. The surgical mask itself is not, at least in our facility, not reprocessed. We have a lot more of those, though we may eventually run out when we have N95s. But if you can keep your surgical mask clean, you can certainly wipe it down. We have not resorted to that yet. If anybody else wants to add preserving surgical masks, please go ahead. Okay, we have a question from Dr. Muhammad Naeem. I think he hasn't spoken yet, so I would give him the opportunity to please ask your question. Please introduce yourself, Dr. Naeem.
Assalamu alaikum. Thank you. I am Dr. Naeem, family physician from Gujranwala, Pakistan. मैं एक दो पॉइंट्स हाईलाइट करना चाहता हूँ. एक तो ये है कि पूरे पाकिस्तान में जो फैमिली फिजिशियन की जो फोर्स है, जिसको वो अलाइनमेंट कर रहे हैं और मोटिवेट भी कर रहे हैं, मोटिवेटर कह लें, प्रोफेसर नासिर शाह साहब. He is not joining this session because this is very important platform to join for the family physician, because a lot of family physicians are being trained by this Professor Naser Shah in Pakistan. He also, I think, have joined Apna Merit conference in RMU, but he is not available in this platform, number one. Second thing is that how many percentage of the healthcare workers who have been infected in USA with COVID-19 and recovered from? What percentage recovered, and how much how percentage of the healthcare workers infected and recovered?
So I think I would begin answer the first question. Dr. Naser Shah, Professor Naser Shah should definitely be on this platform, and I think Dr. Shahid Rafiq will be able to address that. I think that's a great idea. Thank you for bringing it to our attention. Family physicians form the backbone of any medical system, so it's really important to have all of you on board. Secondly, the data on health care workers getting infected varies from country to country. In the United States, by and large, majority of I'm talking about in general, a majority of the cases or patients who get positive have mild symptoms, about 80% of them, and very few get severe symptoms. I don't know the data on how many healthcare workers are infected and recovered and how many have died. So I'd let other panelists answer that question. Perhaps Dr. Cheema has that data.
Right. So I second Dr. Iqbal. We don't have data for the healthcare providers, how many have been affected, or we don't have any data available at this time. But of course, out of total more than 820,000 cases of the United States, and I mentioned about this point something more than 5 point fatality rate. In recovered cases, the data I have so far is more than 82,000 cases have been recovered in the United States. But again, it's all the data is not only the healthcare provider. We don't have data available for the healthcare provider, how many have been affected and how many recovered. But again, overall, I can tell you 81% cases have mild to moderate cases, 14% have severe cases, and 5% have the critical cases. This means 5% need intubation, and of course 14% severe cases, and 81% don't need hospitalization. They need supportive care at home, isolation, and all the supportive care can help. But again, I don't have again data for healthcare providers mortality rate.
There have definitely been incidents where healthcare providers or doctors, nurses have actually contracted the virus and been in intensive care and have passed away. So this always makes big news in the US. But we can certainly provide you with that data. Let me ask the question to you, Dr. Naeem. You asked this question with something in your mind. What are you thinking? Are you thinking about risk to your team? Would you like to elaborate that?
I couldn't understand.
Dr. Naeem? I'm not sure, but we also have Dr. Nigat who wants to make a comment. Dr. Nigat, please go ahead.
Hello?
Oh, Dr. Naeem is back. Yes, Dr. Naeem, my question to you was, we don't have the exact data, but what is your, the reason you asked the question is to assess the risk for your team members, or is there?
Yeah. The data available in exactly is not known in Pakistan, but we see that a lot of health workers, they are infected, they are quarantined ultimately, and somehow or others they can be managed, or they may become fatal. That is why I am seeing that USA, how many healthcare workers have been infected and recovered, but here, that all the treatment is not available in Pakistan, and not taking like in USA. That is why I am asking this. My second question was also that what is the stress level for the COVID-19 patients in the quarantine period? Stress level. They after quarantine level period, do they come and show their distress?
Of course, definitely. Stress level varies from person to person. Again, even patients, stress is all over, right? If patient is positive or not positive, patients, even people staying at home, social distancing is putting a lot of stress, socially, physically, emotionally. We are not seeing our family members. It's not only for the patient. I would say overall, for all it's a big stress globally, the stress level. So we can't measure the stress level. It varies from person to person. But again, we can talk about the coping mechanism, how to deal with it. Being a Muslim, right? We have a strong belief in Allah subhanahu wa ta'ala. We can say namaz at home and pray have strong tawakkul on Allah that it too shall pass soon, inshallah. And this is what we can do. And this all coping mechanism, have a exercise at home. It's 12 o'clock. We can have a healthy diet at home. We can have family activities at home. Again, we are not meeting with a family member who living far away or within a few hours distance. We can have a video conferencing call with them. Again, it varies from person to person which coping mechanism helps you with the stress level. And again, it varies from person to person. And the stress is anxiety, is depression. So depression is lasts for same symptoms with certain few symptoms that last for 6 to 8 weeks. That is called depression. That will start different antidepressant for that. But again, stress and anxiety level is there a coping mechanism we recommend for the patients. And again, it varies from person to person.
Thank you very much. I would like to take a couple of questions. I know we are now 1 hour into this meeting, and I really appreciate the patience of all the panelists and all the attendees. As you know, a lot of questions have been posted in the question and answer session, and we've not been able to answer all of them. But here is some of the question. Dr. Rana Sohail is asking if there is any trial using levermectin for treatment. Dr.
Right, yes, there is antiviral agents available, but still, again, they're under trial. We don't have any scientific data available at this time, and I didn't see anyone using it in the one I'm following. But of course, there was TOSI. I saw a few patients, remdesivir trial, but of course, they are under trial going on in the United States for antiviral agents. But again, no scientific data available at this time for prophylactic use. I saw your question there. He's asking about for the prophylaxis. So I will not recommend. Based on that, we don't have any scientific data available. But for pre-exposure and post-exposure, prophylaxis use hydroxychloroquine, and chloroquine is under trial for prophylactic use. But again, no scientific data available at this time.
So hopefully, at least in a few weeks or so, we might get some encouragement.
Right. Sure.
But right now, we don't have any strong indications of evidence. The other question, which is a kind of an interesting question, is that can we decrease oropharynx, naropharynx, and paranasal sinus secretions by advising warm salted waters? I'm talking about saline goggles and nose rinse 5 to 6 times a day. And now you mentioned one of the studies that did have this in place.
Right.
But there was some exclusion criteria that if the patient had, they were excluded from it if they had certain issues. So is this something that you would advise people to do, at least in the cooperative stages of the disease?
Yes, definitely I would recommend, because this trial has been approved definitely, and that they are recruiting the people for that. So definitely that's why I bring all these trials, exclusion criteria, because we don't have any scientific data to support all these trials, but we can think of starting any remedies to our patient to help. So these nasopharyngeal, these goggles will help with mild to moderate cases. So definitely I will recommend for the patients, and let's see the response. Is 4 times a day they are recommending at this time. And exclusion criteria, again, patient who cannot do it, who don't have any good gag reflex, to avoid any aspiration. So we have to be very careful. We have to assess before referring those patients to start doing it. Again, elderly patients, make sure they are able to do it, or you can ask them to do in front of you, and you can see, okay, how the gag reflex is, to avoid any aspiration concerns.
So one of the interesting contraindications was any respiratory tract disease as a contraindication to the goggles.
Right, definitely.
What does that mean? Why would you?
Right, any acute viral, good question. So it's very acute respiratory disease. It can be COPD, right? It can be asthma. So any respiratory disease can, we have to make sure, like patient has pneumonia, not the viral pneumonia, bacterial pneumonia. So again, we don't have any data available at this time, but we can recommend. But it's exclusion criteria is any respiratory disease, any asthmatic patient we can think of, any COPD, chronic COPD patients. So we have to, again, if you're a primary, I will say from primary care standpoint, if you are a primary care provider and you're seeing your patient, so you can easily assess the patient, whether it's a chronic symptoms going on, it's a new onset, and it will help or not.
Another question by Dr. Nigat is, how are family physicians in different cities reaching out to their patients? Are they using telemedicine, phone, Skype? Now, this question is both for the United States and for Pakistan. So let me go to the panelists from Pakistan and see what we have going on in Pakistan with telemedicine, family physicians. Professor Shamsa.
हेलो
जी हाँ जी फैमिली फिजिशियंस का तो खैर मुझे इतना ज़्यादा पता नहीं है, लेकिन फॉर डॉक्टर निगत ने जैसे ट्रेनिंग की बात की, तो गंगाराम में आज से हम ट्रेनिंग शुरू करा रहे हैं अपने हेल्थ केयर वर्कर्स की, जिसमें डॉक्टर जो फ्रंट लाइन पे बैठे हुए हैं मेडिसिन और गायनी के, प्लस पैरामेडिक्स और नर्सेस। एक तो ये बात, दूसरा मैंने पूछना था फ्रॉम अस्मा, first I would congratulate her for such an comprehensive talk. कि कोई इस तरह का मल्टी सेंटर ट्रायल अगर हो जो जिसमें FJ, because FJ is now designated as center for the COVID pregnant patients, तो हमारे पास सारे पेशेंट आ रहे हैं फ्रॉम लाहौर और इवन फ्रॉम पेरिफेरी, तो किसी में हम भी कोलैबोरेट कर सकें।
Sure, definitely. I will recommend कि जैसे इनका ना वेबसाइट है, आप उधर जाके उनसे ले सकती है। ऐसे जो भी ट्रायल्स हैं वो FDA उनको अप्रूव करता है। अब आई थिंक देयर ऑल द स्टेट बेस है, लेकिन कई ट्रायल हैं जो ऑनलाइन ट्रायल हैं, उसमें पार्टिसिपेट कर सकती हैं। लेकिन उसमें आई हर्ड, I saw a couple of those जो थे, I didn't look in much detail about the pregnant patients, but I think there are, you can participate somehow online, but I think we have to get more information about it. But you can get more information on the FDA website, and of course clinicaltrials.gov. You can go there, and as there are few trials they are accepting online, but internationally how they will accept it or not, that I don't know for sure. But of course we can get more information about it. We need to do some work on it, figure it out.
Okay, thank you.
So Dr. Shamsa, I will speak to my colleagues in OB anesthesia and OB who may have who are very involved in the ACOG and SOAP, which are the two major organizations here, and see. I think you certainly have the patient volume, so they'll be interested if we can get it done. So thank you very much for that suggestion.
Okay.
I think if everybody is still here, 7 minutes past the hour, we had 3 minutes, we started about 4 minutes late. So we can go on just a little bit more because there's a robust discussion.
Sorry, go ahead.
So one of the questions from previous questions was role of convalescent plasma, and you kind of addressed that. So probably, is there anything else that you would like to say about convalescent plasma? Is there something that can be done in Pakistan, for example? Any panelists from Pakistan who can see the logistics of using convalescent plasma in Pakistan?
I think Dr. Bushra should be here, but what I understand is it has already been approved to use it, and the protocols, etc., have been discussed, and I'm hoping that ID people are here. But yes, it is being, it is in the pipeline here also.
Okay, great, thank you.
जी, I will second Dr. निगत, ये ड्रैप से भी वो हो गया है, और वैसे भी इन्होंने जो एथिकल अप्रूवल्स और सारी दे दी हुई हैं। लाहौर में भी हो रहा है एक सेंटर में, और डॉक्टर ताहिर शमसी वहाँ कराची में he is going to recruit the patients.
Excellent. Well, we are not that far ahead. I think there's at least Johns Hopkins has started a study probably 2 weeks ago with convalescent plasma. So it's an experimental therapy. Another question by Dr. Mariam Motin, who's actually present in the panel, is how long does it take antibodies to form? And if there is what's the antibody level that would be considered safe for return to work or normal life after COVID positive status?
Good question. I need to do homework on that to check how much level, but I can tell about this based on the symptoms. If patient is symptom-free for 28 days, and also if 14 days symptom-free and COVID testing negative test. I cannot tell for sure the titer. I have to look into it, but any ID person over here can tell about it. But of course, 28 days symptom-free or 14 days symptom-free plus COVID test negative. But I don't know for sure the titer level. If anyone else in the panelists know about it?
Well, I mean, the question has actually addressed some of the issues around antibody testing, which is still not routinely done in the United States. I think like in our hospital at University of Texas, they've just started to they've developed their own antibody test, but it has not been validated by the state. So they're not sure if they'll be able to use it to confirm immunity and allow people to go to work. So I'm curious to know what is the status of antibody testing or in Pakistan, and if that's part of the national plan or an institutional plan. Well, perhaps we will see if we can do this, again, this question. Then there is another question about mortality in hypertensive is due to endothelial damage or relationship with involvement of angiotensin converting enzyme.
Right. There's a lot of talk about that angiotensin converting enzyme inhibitors should be stopped because of concern for COVID-19 infection patients. But there is a American Association of Cardiology does not recommend it at this time. We don't have any, again, scientifically available. And they recommended the benefits are more than risk at this time. And the patients with the CHF, CAD, hypertension, they should continue taking ACE inhibitors at this time, given we don't have any scientific proven figures available. But they recommended the benefits are more than risk at this time. And so they recommended continue taking ACE inhibitors for patients with heart issues.
Is there any difference between ACE inhibitors and ARBs? Is there a different advisory for angiotensin receptor blockers if the patient is on them?
Right. So there is another study I mentioned. There's one study is going on. I didn't put it over there. Losartan. So they are written as well that they should be given or if we should stop. Again, there's no proven data available at this time, but still under trial. There's a good thing that they are studying losartan at this time.
Thank you very much. Now, this is a really interesting question from Dr. Imjad Hussain, who has asked a couple of questions. I think we can take one of them. Is that as the pathophysiological details of disease is unfolding more and more, do you suggest that keeping in view the high altitude pulmonary edema theory, early use of oxygen could change the course of events? As in, high altitude mountain climbing, the high altitude pulmonary edema can sometimes be ameliorated or even prevented by using oxygen at a certain altitude. If that's the working hypothesis. Is that something that is happening in this, at the pulmonary level in this disease?
Good question. It's a very good question. I don't think so. I didn't see any study on it going on. And I think pulmonologists and critical care will be the best person to answer this. But I am not aware of any study going on or any benefits or anyone talking about it. But of course, we talk about the ECMO, and I shared with you the figures. But I'm not sure anyone, I don't think so. We have any pulmonologists on board today, but we can address again tomorrow.
Okay, excellent. Well, I think we are now almost quarter past midnight on the East Coast in the United States, and we're in 9:15 in Pakistan. So I thank all the panelists, especially the speaker, Dr. Asima Cheema, for an excellent presentation, and all the attendees for a very robust discussion. We learned from everybody who's been here. And lastly, I just want, in the last couple of minutes, if there are any remaining questions people have, I think Dr. Nigat is.
But I have seen the patients in ICU settings who are intubated, all the pulmonologists and critical care are giving them steroids. And with, again, some positive and some without any positive results, but we are using steroids over here in ICU setting, but I didn't see any study. Maybe I missed somehow, but it's a very important question that we need to figure out. But again, there was no recommendation at this time that we should give steroids, but we are using in the ICU. I saw two of my patients were on steroids.
I think that's a great question, Dr. Qureshi. This is one of the big controversies about this disease, that there is it wears several faces, and in the cytokine storm stage or before that stage, if well-timed, steroids could theoretically be of benefit as an anti-inflammatory agent. However, it's none of the intensive care societies have used that as a recommendation as part of the treatment. And if you look at the NIH, National Institute of Health in the United States guidelines, it does not mention use of steroids. However, I know from conversation with Dr. Hadekar, who is at Sindh Institute of Urology and Transplantation, that she has anecdotally observed a very positive response by giving methylprednisone to her seriously ill patients. Again, anecdotally, we hear this, and it makes physiological sense at a certain stage, but you're also talking about an infective process and secondary infection with bacterial pneumonia. So it's kind of, how will you time it perfectly? So until we have a guideline from based on evidence, we can't really say that steroids are universally helpful. But that's a great question.
Thank you. And another question is that regarding your observations, being from the USA, what are your observations? How much it will go ahead? till how much time this process will go on?
Very good question. That's why it's called novel coronavirus. Novel means we don't know. No one knows. So that's really good. But again, preventive measures, precautions is very important. Continuous social distancing is very important. Being a physician in Pakistan, healthcare providers, it's very important. Public awareness in rural areas, and even in cities areas. I'm seeing even in my relatives, it doesn't matter. I said, no, please don't think that everyone thinks it's only in America and European countries. It's very important in Pakistan for public awareness that we don't know what's going to happen next. But again, flatten the curve. Everyone talking about social media. It's very important that we have to do the preventive measures, because we don't have any definite treatment at this time. And of course, the people who are critically ill is really overwhelming for everyone. And again, in America, it's New York and New Jersey. These two states are epicenter at this time, and I can see a lot of frustration. Most of my friends are there, and of course, shortage of PPEs and all this stuff. So it's really a big crisis for everyone globally. So, but I think everyone in Pakistan should take it seriously. It's very important. As a physician, you should spread this awareness, and everyone should take it very seriously to flatten the curve and continue taking precautions at this time.
Thank you. I do have a question for Dr. Qureshi, actually. Dr. Qureshi, you are in Jamshoro.
Yes,
what is
I'm
your experience? How many patients do you have in your institution, or that are positive or seriously?
We have seen more than 10 to 15 patients was positive, but out of them, 10 have been cured well, and 5 were not stable till yet.
Okay. But anybody in intensive care?
Yes, 2 of them are in intensive care out of 5.
I see. Well, thank you for sharing that. I think Dr. Muhammad Naeem has a question, and I think this will be probably the last question.
Thank you very much. Dr. Iqbal साहब
जी जनाब
एक बात हो रही थी कि यहाँ पे पाकिस्तान में फैमिली फिजिशियंस शुरू में जो दो हफ्ते थे उनमें तो वो बड़े स्केर्ड थे और फैमिली की कुछ कदगन लगी तो उन्होंने कहा कि नहीं हमें ये आपको बाहर नहीं जाने देना कोरोना बहुत स्प्रेड कर रहा है now there is the daring step by the general physicians. They are coming to their clinics and opening their clinics and saying giving their medical advices to the routine patients, as well as they are not very much touching to the flu patients or coughing. They refer or they have chart out that they should not come there and they should contact on phone, on WhatsApp. But now there is field is open for the physician, and they are going to their clinics and doing their practices. Thank you.
So is your question whether that's what they should do, or is that a statement of fact that they have to do this?
They should come out of their homes and they should practice, but there should be practical preventive measures they should take and help the patients.
I can tell you that, I, a family physician, whether it is a family physician here or a dental surgeon, they're only in the United States, at least in Texas, they're only treating extremely urgent people face to face. Otherwise, everything else is by either telemedicine, phone, or televideo, and unless you have an unstable condition that needs to be treated. So I think it will be prudent for family physicians to take precautions, at least if they have to see patients, then, maintain a certain distance. If they examine the patient, then make sure they have barrier protection and strict hygiene, hand washing. And of course, because you're dealing with patients who have not been tested, majority of them, so you don't know what their status is.
Yes, of course.
I think the virus, we know in Pakistan, is now in the community, although the government has tried very hard to contain it and, contact tracing and everything. But it is in the community. It is in the community. You have to assume that and take the appropriate precautions. But yes, you have to have a balance. You don't need to be locked in your house, but you have to take precautions, because if you start getting doctors sick, then who will take care of the really sick patients? So I think it's a responsibility that all of us should protect the medical workforce in every respect, as well as serve the people. I think Dr. Nigat has a question or a comment. So Dr. Nigat, please go ahead.
Appreciate it. I know it's midnight, and I really, my heart goes out to all of you for doing all this for us. We should have a session for family physicians, please, because they are the backbone and they are in different cities, and they should know how to keep themselves safe and keep their patients safe. We also know that 25% of them may be. So I think we should have a session for them as well.
I think that's a great idea. So, we'll, I don't know if Dr. Shahid is still on, but I would say that, we should have a special session of community medical practitioners.
And I know Dr. Nasir Shah. I know Dr. Nasir Shah very well. He is at UHS, and, being an adjunct faculty at UHS, I can talk to him. And I think we should really have a session dedicated to just them.
Okay, well, let's do it then. I would appreciate an introduction, and if you can share his email, we'll like to bring him in and have some primary care physicians from the United States. We have quite a few of them who are dealing with this on a daily basis. We'll like to get somebody from an area which is very busy with these patients to see how they manage. But yes, initially all of us were very afraid of going into work or going to the clinics and taking care of patients. I think that has a little bit eased up, at least in the not in other states, not the hot zones maybe. So thank you for that, Dr. Nigat. I think
thank you all, and especially Asma.
Thank you, Dr. Nigat.
Absolutely. So I will bid you all a good day, good morning to you, and hopefully all of you stay healthy and safe, and we wish and pray to Allah that protects us in our country and our people and our families from this pandemic in both countries, in all countries in the world. So thank you very much, Dr. Asma. Thank you to all the panelists. Thank you to all the attendees. And Assalamu alaikum.
Thank you so much. Have a good night.
Thank you.
Assalamu alaikum.